Your screen is visible, sir.
My screen is good. Okay. Yeah. So you can see my screen now.
Yes, sir, it's visible. We can see the presentation. If we can make it full screen,
Oh,
that will be great, sir.
uh, just yes.
I mean, if you are, if it is a PPT file, sir, like
Yeah, it is a PPT file.
there will be option of F5 or full screen, sir, once you. But it's visible, sir. It's readable. But
This
I'm
is okay.
yeah.
Let me see if I can do that.
Or you can just extend the file, sir. So there's a hello from Dr. Abraha. He
Okay.
works in, he's from the city Mekele and he works in Eider Hospital in Ethiopia.
Okay. Great. Great. Good evening. Hello. So is it full screen now? No, still not.
Still not, sir.
I think. Yes.
Sir, there is that icon. I mean, sorry, if you go back to the file, there was that icon, play icon there.
Actually, I'm going to use the new laptop, so that is why I'm having some
No, no, it's okay.
problems.
We can actually see your screen, sir. We can see your calendar, July 27. Yeah, yeah, sir, it's there. So, sir, there
Okay.
is icon. Okay, the file went again, sir. Okay, let's go ahead with
Yeah.
it's visible.
Okay.
Yes. Yeah.
So, good evening, everyone. So today I'll be discussing about the. Actually, I would be more interested in discussing about my journey of plastic surgery. So, in 2012, I finished my MCS from one of the government medical college, one of the good government medical college from India. And after that, I started my practice from Delhi NCR itself. So initially, I joined one corporate hospital, then moved to another one, and that's how it started. And so, having the plastic surgery background, it was always my dream to be a plastic surgeon. So when I put my first foot forwards towards the medical education, so at that time only, I thought that if at all I would be a medical professional, then I would be a plastic surgeon only. So that's how my journey started from there. Then I start progressing towards my goal. And here I am as an HOD of the one of the premier institute in Delhi NCR, which is Artemis Hospital, which is a JCI accredited hospital and catering to different countries of the world. And uh, we as a department, we are a group of three plastic surgeons who are working in coherence with each other. So we are doing all kind of surgeries related to the plastic surgery, whether they are reconstructive, aesthetic, non-surgical, surgical, every sort of plastic surgery you can think of. So we are doing it here, and we have the latest technology as far as the instrumentation and other equipments are concerned. So we are a fully equipped department as far as the plastic surgery is concerned. So I think let me start my presentation. So today I'll be discussing about the my journey from reconstruction to aesthetic surgery. Before that, little bit of history. So when a term comes to our mind, plastic surgery, so it's like I mean it happens to us. I mean in today's words also there are few patients who comes to us and say, "What is plastic surgery? I mean, has it anything to do with the plastics? I mean, are you going to put some plastic in us? No, come on. This is not. The plastic is different, and this plastic surgery is different." So basically, this plastic surgery word comes from a Greekos word, which means plastikos is the Greek word from where this word arrived, which means to form and to mold. So as a plastic surgery, we take the liberty of molding the tissue which is already existing to form a different tissue or to fill a defect or to reconstruct some other part from the available tissues which is there in your body. So basically, we are the jugadis when it comes to the plastic surgery. So we rob Peter to pay Paul. Basically, this is the old synonymous associated with the plastic surgery. So one of my orthopedician, they call us the lipomas of the surgeons, because we can be found anywhere. We can be working with the ENT surgeon, neurosurgeon, urosurgeon, wherever they need that there is some defect of any tissue. They just call the plastic surgeon, and we are the problem solver for that, for most of the specialty. So this is how the plastic surgery word comes into the picture. So this is how I told you. So a little bit interesting history about the plastic surgery. So in 600 BC, there was an Indian surgeon, Sushruta. He described nose and ear reconstruction in his book, which is called Shushrit Samhita. This was there was the oldest documentation of any plastic surgery procedure is there in the history books. So you can say the Indians are the forebearer of the plastic surgery when it comes to the reconstruction. So he was the father of plastic reconstructive plastic surgery. So in World War One, it was the biggest booster for plastic surgery. It gave us two fathers of modern plastic surgery, Sir Harold Gillis and this American doctors, Dr. Wilroy Blair. Gillis even performed the first male to female sex change operation in 1951. So this was a little bit of history about the plastic surgery. So when the term plastic surgery concerned, it's a whole spectrum of procedures or spectrums of surgical surgeries which comes under this plastic surgery. So broadly, we can divide plastic surgery into broad groups: reconstructive surgery and aesthetic surgery. Reconstruction, we can do, we have this trauma reconstruction, oncological reconstruction, and congenital reconstruction wherever there is a congenital defect. And aesthetic surgery, you know very well about the cosmetic surgery. So this is the broad idea about the plastic surgery. Now I will discuss about my journey, how it started, how it evolved with time, and how as a surgeon I learned and evolved in my practice in over the period of time. So early days when I was just finished my education in plastic surgery, I was bubbling with confidence. I was bubbling to do some work which I have learned during my residency period. So I joined one of the hospital in Delhi NCR, and this hospital was very close to me because it was in a industrial area where there were a lot of factories around this hospital. So we used to get a lot of hand injuries. So I started doing replantation at that time with good results, finger replantation in a kid, hand replantation because of the industrial accidents, the whole hand transplant. This is also a very special case to me because this patient came 7 hours late after the amputation because he was struggling with traffic jams, struggling with one hospital to the other hospital. Some refused for the replantation, and they insisted to just do the replantation. So I took up the challenge and did the replantation. So this was the final picture. Though it is not the one of the best, but considering the circumstances which are associated, he had fairly good sensation, some movement also. So I can say even after doing starting the replantation 7 hours, we could achieve good function. in the leg. Another child with toe amputation, we did the revascularization. So this is the final picture. Another industrial accident, multiple finger replantation. We could manage to save two fingers out of the three fingers. Cleft palate repair, obviously, these are the standard cases which we get during our residency program. Cleft palate, cleft lip. So this was the scalp reconstruction. with skin expansion, post-burn raw area, which was grafted. Then we covered the defect with the help of the skin expansion. So these were the cases I was doing in the initial period of my practice. So once the initial 2 to 3 years of my practice passed, then I tend to realize that I was getting little monotonous in my practice. I was getting a lot of these kind of trauma cases, onco reconstructions also I was doing. So then there comes a time that I thought, let's do something different. Let's move into some other part of the plastic surgery. So then after 2 to 3 years of my period, then I went outside, did some fellowship in aesthetic surgery, cosmetic surgery, and then I jumped into the cosmetic surgery. So I started doing these kind of cases, beard transplant. You can see how the post transplant result. Another patient with beard for beard transplant, hair transplant. I started doing these cosmetic procedures. Another patient, middle age patient with baldness, breast augmentation, breast reduction, abdominoplasty with hernia in a patient with hernia. So we did abdominoplasty and hernia repair simultaneously. Mini abdominoplasty for purely cosmetic region. Facelift. You can see the pre and post op results. The jaw definition and chin projection. Rhinoplasty in post-traumatic defect, nasal bone deformity, purely cosmetic rhinoplasty. Another patient with rhinoplasty. So, so this was the time. So I was doing a lot of. I moved into the cosmetic practice, though I was doing the reconstruction also. So we were doing trauma reconstruction. We were doing onco reconstruction and cosmetic cases also. So now the almost 7 to 8 years of my practice was passed. Then I thought, let's do something else. Let's move into the other part of the surgical spectrum as far as the plastic surgery is concerned. So I thought about it. Then suddenly this COVID struck, and everything, I mean, came to an halt. There was no cases. There was a big, the long period of the hospital were closed. They were dealing with the only with the COVID cases. So everywhere there was a curfew-like situation. So we got a lot of time to introspect what we were doing initially and what we can do further. So in that period, in that COVID period, this patient came to me. This 45-year-old person with huge elephantiasis leg. He had some accident in the 10 years back in the groin region, and after that he started having the lymphedema. So this patient, he was barely able to walk. The weight of his left leg itself was 45 kg. So he stopped going to the I mean, his jaw was not, he was not getting any job. So this forced us to introspect. So what we were doing earlier and what we can do further. So I started because I was not doing lymphedema at that time of my practice. So I referred this patient initially to some other hospital who were actively doing lymphedema, but because of the COVID, they were also not doing. They were also closed. So he came to me again. So then we thought about. So was he was just barely had some movement of the ankle. So we thought about doing something for him. So we ordered some specialized microscope in our center along with the lymphangiography machines. So we did lymphangiography. We could find some lymphatics, a few lymphatics which were functional. So we did lymphovenous anastomosis in three places. So his limb girth, which was initially 120 centimeter, came down to 102 centimeter. So again, we did some excisional procedure for him. And after the multiple excision procedures, his limb girth came down to 65 centimeter from 120 centimeter. So this was the final picture after the multiple excisional procedure and LVAs. Now, to prevent the recurrence of the lymphedema again, so we did free vascularized lymph node transfer from the neck region. So we've taken the suprascapular lymph nodes along with the transverse cervical artery and anastomose it with the anterior tibial artery. So this is the picture after 1 year of doing the lymphovenous free lymph node transfer. So you can very well see the limb girth is almost maintained at 65 centimeter even after walking, even after doing some job. He joined one of the job also. He was able to ride his scooty. So he's pretty happy with this kind of leg. So this patient taught us to do something different, which was earlier I was not doing. So I started moving into the super microsurgery of the spectrum of plastic surgery. So we started doing lymphedemas cases also, multiple LVAs in post-traumatic lymphedema. This is a small video about the LVA. Post-filariasis lymphedema, multiple LVAs. And apart from that, we are also moved into the brachial plexus injury. So this young boy with upper brachial plexus injury was not able to even lift his elbow and shoulder. So we did multiple nerve transfer. So this is 1 year after the nerve transfer. He's still recovering, but he's got fairly good amount of abduction and elbow flexion. Another gentleman with upper brachial plexus injury was not able to lift his right right elbow and shoulder. So this is after the multiple nerve transfer. 6 months after the nerve transfer. Penile reconstruction, post-traumatic penile amputation. So we did penile reconstruction with the help of the radial artery forearm flap. Another patient with post oncosurgery penile amputation. So we reconstructed the penis through the with the help of the free ALT flap. So you can say the very good reconstructive penis here. Another patient with jaw reconstruction, ameloblastoma of the jaw, young boy. So we reconstructed the whole mandible with the help of the free fibula flap. So you can say the post-op result, good contour of the jaw. Bilateral breast reconstruction and bilateral prophylactic mastectomy. So we did the reconstruction with the help of the bilateral LD muscle and latissimus dorsi muscle. Breast reconstruction with the help of the DIEP flap. We have taken the flap from the abdomen, low part of the abdomen, and reconstructed the breast. Good amount of symmetry we could achieve in this case. So another patient with mandible reconstruction post cancer. So we, in this case, we even implanted the dental implants also at the same time while doing the while reconstructing the mandible. So this is the final picture of the patient. He even got the teeth fixed also. Chest wall reconstruction post trauma. So we did the chest wall reconstruction with the help of the free ALT flap cover. Another patient with functional muscle transfer. So in this boy, he had this recurrent soft tissue sarcoma of the biceps. So they have removed the whole bicep. So we have reconstructed the biceps with the help of the free LD transfer on the opposite side. So we have anastomosed the vessel, and as far as the neurotize the muscle with the help of the ulnar few fascicles of the ulnar motor fascicles of the ulnar nerve. This is another special case with me. This young boy with osteosarcoma of the lower end of the humerus. Even the epiphyseal was also involved. So the pediatric oncosurgeon, they have planned to remove the lower part of the lower two-third of the uh, femur along with the growth plate. So what we have done, we have taken the free fibula of the opposite leg along with the growth plate, along with the metaphysis of the head of the fibula, so that there is no growth discrepancy even after the reconstruction. So this is the part. This is the removed lower end of the humerus. They have irradiated this humerus. This is called a Kapana technique, where they give the high dose radiation of the removed bone, and in the same time we have harvested the fibula. You can see this fibula, and it was based on the two dual blood supply. This peroneal artery was supplying the shaft of the fibula, and the head of the fibula was supplied by the anterior tibial artery. So we have taken the fibula based on dual blood supply and put the fibula inside the irradiated femur, which they have removed. So this is the post-op picture. You can see the fibula is very well integrated with the rest of the bone. And this is 2 years after the reconstruction. So you can see there is good range of motion. The child is walking without any apparent shortening of the femur. Another patient with crush injury of the foot. Lot of places he was advised the amputation of the foot, but he was insisting for the reconstruction. So we took up the challenge and did the reconstruction. You can see this is the 1 year after the reconstruction. You see the amount of range of motion. So he's walking normally with this foot. So another patient with avian of the head of the femur, a young child, 12-year-old, post-traumatic. There was the necrosis of the head of the femur. So we have done the reconstruction with the help of the free fibula. So this is the pre-op X-ray of the same patient. Intra-op X-ray of the same patient. They have reamed the head of the fibula, head of the femur, sorry. And we have reconstructed. This is the fibula which we have put inside the vascularized fibula, which we have put inside the head of the femur. And this is the post-op result of the same child. The full range of motion without any pain, without any length discrepancy. You can see he's walking around, he's jumping around with the same leg. Pectus excavatum. So we moved into the pectus deformities also, and we started getting a lot of pectus patient. So this patient was presented with pectus excavatum. This young child was from the Uzbekistan. He came to us for the deformity correction. Because of the pre-op deformity, he even had some problem while running. So he was very distressed while running because he used to have this tachypnea because of the compression of the chest wall cavity, chest wall. So this is the post-op picture even after the just after the 10 days after the surgery. You can see that the contour has improved, the depression is already gone, and he is still having recovering with the problem. And this lung capacity has improved markedly. Another patient, another young boy with pectus carinatum deformity. You can see the beak, parrot beak type of pectus deformity. So this is the pre-op picture. This is the per-op post surgical picture. You can see the contour of the chest wall after even just after the surgery. And apart from that, we also moved into the gender reassignment surgery. We are doing a lot of male to female transformation and female to male transformation also. So this is how my journey has evolved over a period of time. Initially, I was doing a lot of reconstruction, then moved into the aesthetic practice. Then in the specific kind of reconstruction, which were very few of the hospitals in India were doing these kind of cases: lymphedema, brachial plexus, gender reassignment, and pectus deformities. These are very specific cases which are there, and very few people around the world, they are doing these kind of cases. So as far as the whole spectrum of surgical specialties is concerned, so we have covered everything, whatever is there in the domain of plastic surgery. So I think you must be having a lot of questions after the presentation.
Thanks,
So
Dr.
yeah,
Pradeep. Yeah, for very
thank you.
informative. I mean, we should give some minutes till they can ask the questions. So,
Yeah.
first question that is everybody's mind is that the cost implications of these surgery. I mean, it would be a range, sir. Every surgery would be different. So, if you can just, give us some the cost
So
aspect.
as far as the cost is concerned, obviously we are way cheaper than the Western world. But it ranges, I mean, as far as the reconstruction are concerned, the microvascular reconstructions are concerned, it range around from 6,000 USD to 9-10,000 USD, depending upon the number of procedures. Sometimes they need multiple procedures. Sometimes they need single procedures, but in a very defined time period. So it depends. So as far as the reconstruction are concerned, whether it stays around 4 to 5 days in the hospital, it ranges from 6,000 to 9,000, $10,000. And when it comes to the purely cosmetic surgical cases, so it ranges from 2,000 USD to 4,000, 5,000, sometimes 7,000. We are even running a campaign also, which is called Mommy Makeover campaign, which includes breast reduction, liposuction, and tummy tuck. So it costs around 7,000 USD, fixed price 7,000 USD. So there is
Uh,
a vast range as far as these cosmetic procedures are concerned.
so, there's a question from Dr. Al Mustafa Nuruddin. The question is, what is the success rates for these procedures?
So when it comes to the success rate, uh, I mean, in the last 2 years, so when it comes to the microsurgical procedures, our success rate was 99.9%. We lost almost only two cases, I mean, two procedures which were not as per our expectations. So the microsurgical work, our success rate is about 99%. When it comes to the cosmetic procedure, it depends upon the patient's expectations. But I mean, you can say like if the patient is fair enough, if the patient's expectations are good, then they can get around 90-95% of success rate.
So one common question, like to your African doctor colleagues, is so in runtime when they see patients, so how do they triage, right? How do they identify based on multiple parameters that this case looks like fit for reconstructive surgery? Or I mean, aesthetic, we understand that the patient demands aesthetic improvement, but the
Yeah, yeah.
reconstructive, trauma based, etc., I mean, that is also a huge part of plastic surgery, the need base, so when the patient has real need. So how do our doctor colleagues from Africa, how do they decide that, this is the trigger, or this is the point at which I should, send the case note to Dr. Pradeep?
Dr. Pradeep. Yeah. So as far as I mean, when you talk about the origin of plastic surgery was basically originated, I mean, developed for reconstruction of the defect, for the reconstruction of the wound. So if you see any wound which is not healing in 3 weeks of time, whether it's a traumatic wound, whether it's a burn wound or some other kind of a wound, maybe it could be because of some cancer. I mean, resection. So if any wound which is not healing, even after 3 weeks, it needs some plastic surgery intervention. So this is one part. If any wound which is not healing for at least 3 weeks, then it will anyhow will need some surgical intervention. So you can directly send the patient query to us. Apart from that, if there is any congenital defect, obviously you know that there could be some hand defect, there could be some facial defects like clefts or any soft tissue deformity. So you can directly send the patient those kind of patients to us. Apart from that, there could be some cancerous lesion in the skin. So that also we are dealt by the plastic surgeon only, where we do the excision as well as the reconstruction also. So these are the few trigger point which anyone should have the knowledge. Apart from that, specifically we are doing lymphedema also. So any patient which has the edema of the leg, which is not going even after the limb elevation, even after the conservative management, then those patients need some surgical intervention from a plastic surgery point of view. So these are the specific triggers which you can see, and then accordingly you can send those patients to us.
Okay. So, sir, there is a question from Dr. Sunday. He's a surgeon practicing in Lagos in Nigeria. So his question is, can can he be can they access? I mean, given the constraints, so some courses or some fellow. I mean, the question exactly is, can we be given an opportunity to access the course and be trained through Jivo to partner further? So, are there some courses which are being run by Artemis, especially for plastic surgery domain, because a surgeon can develop more skills, fellowships, etc., which we can educate and figure out a way how they can train. Remotely is best, but maybe so if you can give some
Yeah.
light on that, sir.
Yeah. So we are in the process of developing a fellowship in our department. Maybe in 2-3 months time you can get those kind of information about these courses. So mostly we will be starting the fellowship in the microsurgery as well as the maxillofacial surgery. So these are the fellowship we are in process of getting started from our department. Apart from that, we are also in a process of starting the online course as far as the plastic surgery is concerned. So we are developing an app, and we are putting all the information in those apps. So you can also subscribe with those apps, and you can get all the information, all the study material as far as the plastic surgery is concerned. So maybe in another 2-3 months time, you will get the information, and you can very well join those courses.
Dr. Pradeep, our team will chase you for this because this is
Thank
very
you.
much necessary for making it accessible to our doctors, because this is super necessary in capacity
Yeah,
building
I know.
and enhancement. And so
Yeah,
there is another
obviously.
question from Dr. Dinawal. Dr. Dinawal practices in Ethiopia. So what is the golden time for amputated part of body to reconstruct and have a good outcome? Does it differ from body part to body part?
Yes, it differs from the body part of the body part. So basically, when we talk about the replantation, reconstruction, we are talking about the limbs only, hand or leg or foot. So for the golden period for the arm, it is 4 hours. So within 4 hours, you should start the reconstruction whenever there is a amputation through the arm. For the forearm, 6 hours. For the fingers, you can even wait for 8 to 10 hours. And apart from that, there is a warm ischemia period and the cold ischemia period. I'm talking about the warm ischemia period where the amputated part was not properly preserved. So if there is an amputation through the arm, you should start the procedure as early as possible within 4 hours time. If the patient comes to you 6 hours, 7 hours, or 8 hours, so we have initially in my practice, I attempted to do the replantation, proximal replantation at 10 hours, 12 hours, but the post-op period is very shaky. And I learned my lessons. Then you should not attempt proximal replantation. If he comes within four, he should attempt within 4 hours, max 6 hours, not beyond that.
So now, sir, that brings to the question that, in an international cross-border setting, that thing is not feasible. So
Yeah.
many times, sir, the surgery happens, but with not the best outcome. So is there a hope for such patients that later on, let's say 2 months down the line, 6 months down the line, if they come to India, will they meaningfully benefit? Like, can a surgeon like you do do some improvement?
Yeah, we can do, because when it comes to the hand, fingers, we can do the toe transfer for the hand. From one of, if the one of the finger is amputated and it was not reconstructed, so we can do the toe transfer, and it also got good amount of functional benefits. Apart from that, in few centers, not ours, so few center have started doing that hand transplant also, cadaveric hand transplant. But we are in the process of, maybe in another 1 year time or 1.5 years time, we will also start the hand transplant program in our department also. But as of now, we are doing for the fingers, we are doing toe transfer. And apart from that, we are doing cosmetic rehabilitation also, as in the form of the prosthesis. So we are doing permanent prosthesis also, osseointegrated prosthesis also for fingers, for hands. And apart from that, there are options of the bionic hand, myoelectric hands also, which are available for these patients.
So, sir, there is another question. Like you mentioned, cadaver hand transfer, but there is a legal law in India for international cadaver organ is only for Indian citizens, not for international patients. So that would be
Ye-
ruled out for
Yeah,
patients.
yeah, yeah. Yeah, that is ruled out for the international patient.
So there is a follow-up question from Dr. Al Mustafa Nuruddin. He had asked that question about success rates of these procedures. The question is, how about anticipated complications associated with these procedures?
I mean, there are, I mean, as far as any surgeries, there are a few complications also. But we weigh the outcome. I mean, the cost and benefit analysis. We do cost and benefit analysis for these kind of patients where we are suspecting that there might be some post-op complications. So just like any other surgery, there are chances of 4 to 5% complication each and every case. But we developed a few protocols in our department, so as to minimize those complications. But
And sir,
anyhow, uh,
sorry, I interrupted you. Continue.
no, it's all right. You can continue.
No, sir, my sir, what are the nature of these complications? So, I mean, the
So it,
broad.
it depends on, yeah, it depends upon the patient to patients. There are few patients, as far as the aesthetic procedures are concerned, there are patients who are very much prone for the keloid scarring, keloid tendency. So they might get some keloid formation as far as the cosmetic scarring is concerned. There are few patients which have some comorbid associated comorbidity like diabetes, hypertension, thyroid. In those patients, there are chances of complication which are more, like they can have the wound descent, they can have there can be chances of infections also. So wound descent, infection, uh, hematoma formation, seroma formation. These are the common complication. I would not say complication, side effects of these procedures.
Okay.
That's all.
So now there's a question from Dr. Abraha. He's from Ethiopia. So this question is, what were your pre-surgical evaluations on the brachial plexus injuries?
So for all these patients, first of all, we do the clinical examination. Then we do the NCB EMG. And apart from that, we do the MRI. So MRI is one of the essential. So first we do the clinical evaluation and map out the plan for the these kind of procedures, that what are the deformity that these patients have after the brachial plexus injury. So on the basis of the clinical information, we check out the plan. And apart from that, we do the NCB EMG to see how many donor nerves or donor muscles which are available for the transfers. And apart from that, we do the mapping of the brachial plexus with the help of the MRI. So these are the three things which we do for these kind of patients. And yes, we are managing birth brachial plexus also. We are managing adult brachial plexus also, traumatic, even the oncological patients also. We are doing reconstruction in as far as the brachial plexus injuries are concerned.
Okay. So now there's another question from Dr. Abraha. So he asked, do you repair Klumpke's palsy, birth trauma, if it remains so, I mean, compromising physical dexterity later in life?
Yeah, we are doing even 2 days back, we have operated one of the patient of birth brachial plexus, 2 year old child with birth brachial plexus. So we are fairly managing
No,
the
no, he's asking
kids
about
also.
uh, clump case palsy, butt trauma
Yeah.
later in life.
This is yeah, no. Yeah, clump case paralysis is the birth paralysis also. Whenever usually, sometimes what happens, the gynecologist, they pull the hand and they got the stretching injury of the brachial plexus. So we are managing all these patients.
Okay. Now, so there's a question from Dr. Orana Paul. He is from Nigeria. So, what is the lowest age limit for aesthetic surgeries?
So usually we do aesthetic procedures when the growth of that part is complete. Let's say if we are talking about the face or nose or something. So usually we say that in 15 years time, the growth of the face is complete. So the face is as the face of a 15-year-old child is as good as the adult child. So usually the minimum age as far as the face is concerned for any procedure is 15 years, maybe 16 years. So after 15 years or 16 years, we can do any aesthetic procedure on the face. When it comes to the other part of the body, we say that 17 or 18 years of the age is the optimum age, because at that age they are wise enough to think about their body image, and they know about the implications of those aesthetic surgery. So in our center, we are doing cosmetic procedures for the face of a 15-year-old child also, and the adult child also.
So, are
So the
these
minimum age,
sorry, sir, sorry. So,
no, no, it's all right.
are these governed by any so regulation? Like in India, we have about many things
No,
consent
no,
18.
no,
So,
no, no. There
parental
is no
consent is enough.
like it's just
Parental.
the medical.
So, in case of a minor like 15, 16, parental consent is enough for you.
Yeah. Parental consent is enough.
Okay. Okay, so Dr. Anwar, the second question. Okay, is the same question. What is the lowest age limit for aesthetic surgery for children? Now we have a question from Dr. Destin. He is from Rwanda. His question is, can you repair mandibular deformation? It's a congenital malformation. Mandibular
Yeah,
deformation.
yeah, yeah. We are doing all the orthogenetic surgery as far as the mandible and maxillary deformities are concerned. So we are fairly managing all these cases. No problem.
And sir, okay, Dr. Abraha, thank you for your responses. So,
Thank you.
any other questions? If you don't have any question immediately, if you have any patient case notes, you can share it in your Jivo work group with your Jivo relationship manager. We will direct it to Dr. Pradeep. Dr. Pradeep, it would mean a lot, if you can. Because in cross-border healthcare, it lacks structured clinical pathways, which we are trying to build in partnership with hospitals like Artemis and others, and doctors like you. What we want to do is build a structured referral pathway between a practicing doctor there, like Dr. Abraha or Dr. Orona Paul, and doctors like you. And second, we are building protocols around like when to refer the patient case, how to document the case file, the opinions, and those online consultations. So after this, we would probably seek a time with you where the doctors can pre-share their cases, and we can organize it like a OPD, the online version of OPD. So I mean, some words from you in the merit of this approach, because this industry is infested with agents who misguide patients,
Yeah, yeah.
bring a bad name to India. I think India should be health capital of the world, like China is manufacturing capital. That's the potential of our country, and how doctor to doctor pathways, they are better for patients and they build more trust. But if it comes from you, it will mean more than coming from me. So if you can spend 2 minutes on that for encouragement of our doctor partners.
Yeah, definitely. I mean, being a medical professional, if we interact directly to the referring doctor or referral based doctors group, so they understand the medical implications, and what could be the best way to go forward for referring these patients. Because yeah, you are rightly said, this industry is also now full of a lot of agents who gives uh, who were spreading a lot of misinformation as far as the medical health is concerned. So definitely, if we can build up a platform where we can interact with different specialities, different doctors of the other part of the world, so it would be a best way to go forward. And India has a lot of potentials. As far as in the last 10 years, I have seen a lot of improvement as far as the health infrastructures of our country is concerned. We are seeing a lot of big corporate hospitals which are coming up with latest equipments which are available all around the world. Even the manufacturing capabilities of Indian companies has increased by leaps and bounds. So we are. I mean, as if you compare us with any European setup, so we have all the facilities which are there, which are available at our disposal to treat any kind of patients all over the world. So you and apart from that, we have specialists. I mean, the this industry is based on the doctors. So
Yeah.
if the doctors are qualified enough, and then and they are well equipped with the equipments, and they are qualified enough to perform any procedure. So this is the best thing which can happen to any health infrastructure. So we have the best specialist available in our country to perform any procedure, to perform any surgical work, which is there in all over the world. So I think India is growing by leaps and bounds as far as the medical infrastructure and medical specialities are concerned. So we have a lot of now. Apart from that, we are also spreading in our, I mean, our hands in the AI system also. I mean, as far as the latest technology are concerned, a lot of doctors are there moving into towards these technologies. Like you will find almost the robotic penetration of India in last 2 years. It was like in the major cities, it is 70 to 80% penetrations of robotic surgeries is there in any hospital. So we have done a remarkable job when it comes to the technology as far as the specialty specialist work is concerned. So definitely, if we interact with other countries and we can develop a referral based program where a doctor can directly interact with another doctor, that would be the best thing which can happen
Well,
to
sir, you
our
will,
industry.
Dr. Pradeep, you will experience when any of these doctors they share, you will realize that all are concentration structured that are along with the patient, the local doctor also attends, and you will see the difference. Another thing, sir, you can also share like how at least till our generation, how Indian education system was. Any kid who is bright, the default options are medical or IIT. You must have also faced a lot of pressure as a kid. I went to
Sure,
IIT,
sure.
so huge. So if we can touch upon that, the brightest join the medical field. I mean, in India, the
Yeah,
brightest kids
yes,
join the
yes,
medical field.
yes,
Very
yes, yes,
competitive.
yes, yes. Medical, I mean, not only the medical, the every professional program which is there in India, it's a very competitive. Only the tip of the that spectrum they goes into the system. So there are two parallel systems which are running in our country. One is the government-based system, and one is the private-based system. Initially, the government-based system was the only system which was available in India, and to go get into that government-based system and program was the hell of the job. I mean, we lost 2 to 3 years preparing for that to enter in that system. To I mean, if you get selected in any medical government college, then you are the top 5% of the all the students which are preparing for the medical jobs. So only 5% get the admission in the government medical system. Now there is a parallel private system is also now catching up. They also they are doing very good job. But still, the best thing is the government system, which very few can enter, and whoever enters, then you can think that I mean, you can say that they are the best in the field. So getting into the medical or the engineering or any professional field is a tough task, and only the top tier, top intelligent students, they go into that system.
And sir, there is a thank you message from Dr. Abraha. I mean, true, and about your skill of Indian surgeons. True, and we are very grateful for the opportunities India and Indians are offering to us. Most subspecialties in his hospitals were trained in India. So yeah, that's a validation also.
Thank
Uh,
you. Thank you.
I think we don't have any follow-up question. Thanks a lot for your time, Dr. Pradeep, and thanks to all the doctors who attended. I understand in medical profession, Sunday is the only day you get unless there's an emergency for your family. And thanks for taking time out for this these sessions. And I hope this is how movements are built. Early adopters do good work, and let's together change how cross-border patient movements happen and how cross-border doctor collaboration happens. Thanks a lot for your time, everyone. I mean, my heartfelt gratitude. Thank you.
Thank you. Thank you. Thank you. Pleasure being here. Pleasure being interacted with you. Thank you.